Yeah, so exactly. So it was streaming yet.
Yeah, it was not streaming because 1 second now.
Yeah.
So am I audible now? So
Yeah.
audible Kavya? Oh, sorry, audible Diksha?
Yeah. Yeah. That's it is not anyway there.
No, obviously the YouTube sessions will there will be a lag.
Okay. Okay. So I think everything is fine.
Okay. Yeah.
Yeah. How's it go?
Right. Thank you very much.
No go.
Yeah. Yeah.
How's it go?
Right. Thank you very much.
No go.
Yes. So I'm very sorry for that. There were some technical issues. So we will just resume back to the discussion on the questions of the hemolytic anemias. Right, just please give me a thumbs up if I'm audible to all of you. Alright, so the first question is, all of the following causes the intravascular hemolysis except mismatched blood transfusion. Yeah, very good. Thank you very much. So mismatched blood transfusion, snake bite, thalassemia, paroxysmal nocturnal hemoglobinuria. Yes, please answer this question. Very good, Mahak and Tawheed Khan. So the thalassemia, if you see, you will not have intravascular hemolysis. Thalassemia is a condition where you will have extravascular hemolysis. Right? So can anyone tell me what is the site of that extravascular hemolysis? Yes, what is the site of extravascular hemolysis in patients with the thalassemia? So the site of extravascular hemolysis in patients with the thalassemia is within the spleen. Right, so that is the site of hemolysis. Whereas you take mismatched blood transfusion, snake bite and paroxysmal nocturnal hemoglobinuria, so all of them they get hemolysis within the vessel. They are all your intravascular hemolysis. Your option A, B and D. But whereas C, that is your extravascular hemolysis. Okay. Now, after having discussed about this, we will move on to the next question. Hemoglobinuria may be seen in all of the following conditions except mismatched blood transfusion, paroxysmal cold hemoglobinuria, thermal burns, hereditary spherocytosis. So hemoglobinuria, it's a condition which is characterized by the presence of the hemoglobin within the urine. Right, very good, Mahak. So the answer is the hereditary spherocytosis. Now, one important point that you should understand here is the hemoglobinuria will be there if there is presence of intravascular hemolysis. Right, intravascular hemolysis. Now you take your first three options. Yeah, very good, Tawheed Khan. Mismatched blood transfusion, paroxysmal cold hemoglobinuria, thermal burns. In all these, there will be presence of the intravascular hemolysis. Right? Whereas You take in hereditary spherocytosis, that will be extravascular hemolysis, right? That will be extravascular hemolysis. Now, can anyone tell me what is the site of hemolysis in hereditary spherocytosis? What is the site of hemolysis in extravascular hemolysis? Sorry, in hereditary spherocytosis. And this hereditary spherocytosis is a condition which is characterized by the biconcave shaped RBC will become the spherical shape. Right? Very good, Mukherjee. So the site of the hemolysis in hereditary spherocytosis will be in the spleen. Right? Next. Please tell me this question. What is the most common protein which is being deficient in hereditary spherocytosis? What is the most common protein which is being deficient in patients with the hereditary spherocytosis? So basically the defect is absence of protein within the cell wall of the RBC. No. It is not the spectrin. Very good, Avinash. So Avinash has answered this question correctly and followed by others. Right? Ankyrin. Right? Ankyrin. Ankyrin is the most common protein which is being deficient. Then followed by that we have other proteins like your spectrin and all. But here the most common protein which is being deficient in hereditary spherocytosis is the ankyrin. Okay? Right. Then followed by that we will move on to the next question. Yeah. Hemoglobinuria does not occur in copper sulfate poisoning, snake bite, mismatched blood transfusion, thalassemia. So, right, very good, Avinash. So again the same story. Copper sulfate poisoning, snake bite and mismatched blood transfusion, all these are the intravascular hemolysis. Thalassemia, you will have extravascular hemolysis, right? So that is the reason why you will not have the hemoglobinuria in patients with the thalassemia. Either you take beta thalassemia or you take alpha thalassemia. Hemoglobinuria will not be there, right? Next. Yeah. Haptoglobin levels are decreased in mismatched transfusion reactions, thalassemia, G6PD deficiency, all of the above. So before that, I will ask you a question. What is haptoglobin and where is the site of synthesis of haptoglobin? Yes, where is the site of synthesis of the haptoglobin? Right, so very good that everyone is answering all of the above. So first of all, can anyone tell me where exactly is the site of synthesis of this haptoglobin? Very good, Amol Sangle. So the site of synthesis of the haptoglobin is within the liver. Now, whenever there is hemolysis, so all these are the conditions where you will have the hemolytic anemias. So hemolytic anemias, in the sense, what will happen? The hemoglobin will be released into the circulation. This hemoglobin will bind to the haptoglobin which is present in the plasma, synthesized in the liver. So now this hemoglobin haptoglobin complex will be formed. So thereby what will happen to your haptoglobin levels? The haptoglobin levels will be reduced. So in majority of the hemolytic anemias, you will have the hemoglobin released into the circulation. Yes, Avinash, haptoglobin levels are decreased in all the conditions, right? It is not just only mismatched blood transfusion. So the answer is D. The answer is D. Okay. Then followed by that, if you see the next question. Yes. Chronic hemolysis from which of the following condition may be associated with iron deficiency, paroxysmal cold hemoglobinuria, thalassemia, hereditary spherocytosis, G6PD deficiency. Yes, Mahak Balani, even in your extravascular hemolysis also, the haptoglobin levels will be reduced, because in extravascular hemolysis, the hemoglobin from the spleen and as well as the liver, it will be spilled into the circulation. Chronic hemolysis, from which of the following conditions may be associated with the iron deficiency? Right, so I'm getting a mixed answer for this, but the answer to this particular question is paroxysmal cold hemoglobinuria. Right, so chronic hemolysis, no, I did not get the correct answer from any one of you. Chronic hemolysis due to paroxysmal cold hemoglobinuria may be associated with the iron deficiency. Right, why? Because in chronic extravascular hemolysis, iron is tenaciously conserved, and in chronic intravascular hemolysis, the large amount of iron is lost in the urine as the free hemoglobin, methemoglobin and hemosiderin, and the patient will become the iron deficient. The patient will become iron deficient, right? Very good. So only Ashutosh has answered this question. Very good, Ashutosh. So the answer is the paroxysmal cold hemoglobinuria, right? Whereas you take all these conditions, thalassemia, hereditary spherocytosis, G6PD deficiency, all these are the extravascular hemolysis. So in extravascular hemolysis, the iron, it is conserved, it is not being deficient. Whereas if you take the intravascular hemolysis, that is your paroxysmal cold hemoglobinuria, this particular iron, it is being lost either in the form of hemoglobin directly, or in the form of methemoglobin, or in the form of hemosiderin, and thereby that will cause the iron deficiency. Okay, so the answer to this particular question here is the paroxysmal cold hemoglobinuria. Majority of you have said this incorrectly. The answer is A. Right. Yes. This is another very interesting question. All of the following are the features of the hemolytic anemia except decreased RBC lifespan, decreased haptoglobin, unconjugated hyperbilirubinemia, bilirubin in the liver, altered erythroid and myeloid ratio. Which of the following are not the features of the hemolytic anemia? Which of the following are not the features of hemolytic anemia? Yes, Tejas, you will not have decreased haptoglobin in hemolytic anemia. Right. So, see, there will be decreased lifespan is a correct option. Decreased haptoglobin will be the correct option. Unconjugated hyperbilirubinemia is a correct option. And there will be altered erythroid to myeloid ratio is also a correct option. Why? Because there is anemia. So what will happen? There is excessive production of erythroid series compared to that of the myeloid series. So there will be altered erythroid and myeloid ratio. Now the presence of bilirubin in the urine, it is not correct. So which type of bilirubin will be there? There will be presence of unconjugated bilirubin. If you take all the options, among all the options, the D, it looks incorrect. Okay. So if you are telling that bilirubin is present in the urine, what does it mean? It tells you that there is presence of conjugated bilirubin in the urine. So do you think that the conjugated bilirubin will be increased in hemolytic anemia? No. The type of bilirubin that will be increased in hemolytic anemia is unconjugated bilirubin will be increased. Right, unconjugated bilirubin will be increased. Okay, so presence of bilirubin in the urine tells that there is increase in the conjugated bilirubin. That is an incorrect statement. There is increase in the unconjugated bilirubin. Right, so there is increase in the unconjugated bilirubin that will be there within the urine. Okay, but not your conjugated bilirubin. Right, next. Okay, so if you see the next question, all are seen in hemolytic anemias except Hemocytonuria, reticulocytosis, spherocytosis, increased haptoglobin. All are seen in hemolytic anemias except. Right. So the point is that you should not get confused with the spherocytosis. The point is that you should not get confused with the spherocytosis. Okay. So the answer is the increased haptoglobin levels will not be there. Now, when the RBCs, like spherocytosis is one of the type of hemolytic anemia. So spherocytes can be there even in hemolytic anemia if the cause of the hemolytic anemia is the hereditary spherocytosis. So Hemocytonuria can be there, reticulocytosis can be there, spherocytosis also can be there in these patients with the hemolytic anemias, right? But the one which you don't see in the hemolytic anemias is the increased haptoglobin will not be there. So there will be decreased haptoglobin in these conditions. Okay. All are the features of hemolytic anemia except thrombocytopenia, hemocytonuria, decreased haptoglobin, raised indirect bilirubin. Yes. Very good, Tawheed Khan. So in these patients, they will not have thrombocytopenia. In hemolytic anemias, thrombocytopenia is not there. Whereas you take all other options, there will be hemocytonuria. Right? See, what will happen is, whenever there is hemolysis, the hemoglobin is released into the circulation. This hemoglobin, it breaks into heme plus the globin. Right, heme plus the globin. Now this particular heme, it contains iron plus protoporphyrin rings. Right, it contains iron and protoporphyrin rings. Now this particular iron, when it is getting excreted in the urine, that we call it as the hemocytonuria. That we call it as hemocytonuria. Okay, and this particular raised indirect bilirubin, that can be there in these individuals because whenever the hemoglobin is broken, there will be increase in the unconjugated bilirubin. Right, there can be increase in your unconjugated bilirubin. Okay, now we will see the next question. So the point is that thrombocytopenia, it is not the feature of the hemolytic anemias. Next. Features seen in hemolytic anemia are all except teardrop and Burr cells, decreased haptoglobin, reticulocytosis, hemoglobinuria. Right, so very good. So the answer to this particular question is the teardrop and Burr cells. So teardrop and as well as the Burr cells, they are not the features of the hemolytic anemia. Why? Because this teardrop and as well as Burr cells, they are present in many other conditions. They are not just suggestive of only hemolytic anemias. Whereas definitely there will be decreased haptoglobin, reticulocytosis will be there, and hemoglobinuria will also be there. Now let me discuss few points about this, the teardrop and as well as the Burr cells. Now, you see this slide. If you take the Burr cells, they are present in the microangiopathic hemolytic anemia. But the point is, Burr cells, they are not only seen in microangiopathic hemolytic anemias. There are many conditions where you will have this Burr cells. That includes renal failure, liver disease, burns, pyruvate kinase deficiency, gastric ulcer, cancers, and microangiopathic hemolytic anemias. So these are all the conditions where you can have this particular Burr cells, right? Whereas you take the teardrop cells drop cells, they are characteristic feature of the bone marrow fibrosis. So this is a very important point that you need to remember, right? Now, what are all the conditions where you can have these teardrop cells? Myelofibrosis and myelodysplastic syndrome, sideroblastic anemia, metastatic marrow infiltration, and these may also be seen in thalassemia, pernicious anemia, and iron deficiency anemia. So these are all the conditions where you will have the teardrop cells. So there is differential diagnosis for the Burr cells which are present in your peripheral smear. And there is also differential diagnosis for the presence of the teardrop cells in the peripheral smear, right? So these two you need to remember. The presence of Burr cells is not just only seen in microangiopathic hemolytic anemia, it is seen in many other conditions. Okay, answer this question. Reticulocytosis is not a feature of paroxysmal nocturnal hemoglobinuria following acute bleeding, hereditary spherocytosis, anemia in chronic renal failure. Right, very good, genuine. So in anemia or chronic renal failure, right, so anemia in chronic renal failure, the reticulocytosis is not seen. It is not a feature at all. In anemia in chronic renal failure, in fact, there is a decrease in the retic count. Whereas you take in all other condition, the remaining condition, there will be increase in your reticulocytosis. Right? I'll just show you a table where there is increase in the reticulocyte count and where there is decrease in the reticulocyte count. So please see this table here. Okay, so I have one more question related to your reticulocytosis, and then following that we will take up the table of decreased reticulocyte count and increased reticulocyte count. Right, now you just see one more question related to your reticulocytosis. Reticulocytosis, it is seen in all except paroxysmal nocturnal hemoglobinuria, hemolysis, hereditary spherocytosis, dyserythropoietic syndrome. All right, very good. So reticulocytosis is in patients with the dyserythropoietic syndrome. Now, you should understand what exactly you mean by this word dyserythropoietic syndrome. See, dyserythropoietic syndrome means it is a group of hereditary refractory anemias characterized by ineffective erythropoiesis. Right? So erythropoiesis does not occur appropriately. That is why it is given the term dyserythropoietic syndrome. So when erythropoiesis is not occurring appropriately, so why do you think that the reticulocytosis will be there? No, reticulocytosis will not be there. Now let me just show you the table about the retic count. Now, the point is you take in all of your nutritional anemias. Like what are those nutritional anemias? Like iron deficiency anemia, and as well as the vitamin B12 deficiency, and as well as folate deficiency. So in all of your nutritional anemias, you will have low reticulocyte count. That's the first common thing that you need to know. Iron deficiency, folic acid deficiency, and B12 deficiency. Whereas you take in all of your hemolytic anemias, right? Either it might be extravascular hemolysis or it might be intravascular hemolysis. In hemolytic anemias, let me tell you, there will be increase in your retic count. Why? Because in hemolytic anemia, there is increased proliferation of the bone marrow. Right? There is hyperproliferation of the bone marrow, and that is the reason why they'll have high retic count. Whereas low retic count is seen in thalassemias, leg toxicity, anemia of the chronic disease, red cell aplasia, Fanconi syndrome, marrow damage, right? So you can go through the entire list. Okay, even in hypothyroidism, vitamin B1 deficiency, that is your thiamine deficiency, liver disease, alcohol. So in all these conditions, you'll have the low retic count, right? Now, let me just ask you one more question. Yeah, this question you people have just answered. Yes. Now, last two more questions related to your hemolytic anemias. Indirect Coombs test will test the antibodies attached to the RBC surface, antibodies in the serum, antigens attached to RBC surface, antigens in the serum. Good. So the indirect Coombs test will diagnose the presence of IgG antibodies which are present in the serum, right? Which are present within the serum. Okay. So the answer is B, right? The answer is B. And you take one more question related to your Coombs test. Whereas you take the direct Coombs test. Direct Coombs test will detect the antibodies which are present on RBC surface, in the serum, attached to RBC surface, antigens in the serum. So what is the correct answer for this question? No. See, yeah, the answer, yes, Tawheed Khan, the direct Coombs test will not detect the antigens, detect the antibodies which are present on the RBC surface. Right? Okay, so direct Coombs test, antibodies on the RBC surface. Indirect Coombs test, the antibodies in the serum. Right? Indirect Coombs test, antibodies in the serum. And antibodies attached to the surface, that is your direct Coombs test. Right? So these are the questions related to your direct Coombs test and as well as the indirect Coombs test. Right? So these are some of the questions related to the So these are some of the questions related to general features of the hemolytic anemias, right? And you take the remaining hemolytic anemias like hereditary spherocytosis, all that we have discussed in detail on Unacademy platform in special classes. But the general features of the hemolytic anemias, there I did not discuss. So that is the reason why I have taken the multiple choice questions of the general features of hemolytic anemias in this particular session, right? So yes, I hope like you people have learned something in this session. All right. So thank you very much. Good night and see you in the upcoming sessions.